Hello, good afternoon, everyone. Happy Friday. I am Krista Droback. I'm a partner here at Serona Strategies. My partner, Kristen McGovern, is also here. This is the first of a series of flash webinars. They are 30 minutes intended to provide relevant and top of mind policy issues in bite sizes. So we don't want to have long droning on webinars. We just want to briefly discuss things that are happening. My background is deep in Medicaid. I was the deputy director of the Illinois Department of Healthcare and Family Services, where we oversaw the Medicaid program. I was the director of the health division at the National Governors Association, and I also worked in Medicaid at CMS. So today we're going to talk about Medicaid and reconciliation. Serona Strategies, just very briefly, we are a healthcare consulting firm here in Washington. We work on Medicare, Medicaid, health IT, digital health, new models of care, value-based care, Medicare Advantage. So we really run the gamut in terms of strategies and tactics here in Washington. So there are probably varying levels of knowledge about budget reconciliation and Medicaid on this webinar. So let me just briefly say that the reconciliation process is a very unique and powerful tool here in Washington. It requires only a simple majority vote for passage of legislation in the Senate. It is utilized when both parties, a single party controls both chambers and the presidency, and has been used by both parties over the decades. It is a complex process. There are a lot of rules associated with budget reconciliation. It is a two-part process where the budget committees in the House and Senate come up with budget resolutions and then send instructions to the committees of jurisdiction to come up with legislation that meets those budget targets. We are obviously expecting that the House Energy and Commerce and the Finance Committee will be focused on the Medicaid aspects of budget reconciliation. But there are other priorities that are really top of the list in this year's reconciliation package, and that is extending the Tax Cuts and Job Act, otherwise known as the Trump tax cuts, border security, energy, defense, and then there probably will be some Affordable Care Act action as well, and potentially the debt limit. So anyone can raise a point of order in the budget reconciliation process. So you will see over the course of the next few months, lots of discussion of the Senate parliamentarian. The leaders obviously don't want budget points of order raised about the package. So they will be carefully working with the parliamentarian to ensure that the policies that are within the budget reconciliation package meet all of the rules. So just to level set here, this is a very simplified discussion of Medicaid policies that are being considered for Medicaid for the budget reconciliation. Any one of these topics could fill up an entire webinar. So if you note that there are details missing, it's just because we're trying to really get the major pieces into this 30 minutes. Reason we're talking about Medicaid today, in part, it's because Medicare and Social Security have been taken off the table for the reconciliation process, and there will be a need for offsets for some of the other spending priorities and tax cut priorities in the budget reconciliation process. So in addition to the leadership of the party today wanting to reform Medicaid, there's also a practical reason for it to be part of reconciliation, and that is the need for savings that then can offset other parts of the package. We don't know what's going to be in the Medicaid provisions yet, and in fact, I don't think the decisions have been made yet. So we have speculated based on previous bills including the last reconciliation bill that was run under the Trump administration in 2017, and the writings of some of the folks who are in leadership today, as well as discussion in Project 2025 or the Republican Study Committee. So we've really drawn from a lot of different sources to make an educated guess about the policies that will be proposed. One thing I just wanted to mention to keep in mind is the Loper-Bright decision, Supreme Court decision from last summer, will impact the length of the bill. I know that we talked before the holidays about big, lengthy, lots of pages, pieces of legislation, but the Loper-Bright decision will require or basically necessitate that there will be detail written in statute that may otherwise have been left up to the agencies. So this will be a long and complex piece of legislation, most likely. Also, I did want to mention that yesterday, Drew Schneider, the Mississippi Medicaid director, was named to lead the CMS department agency overseeing Medicaid, and will probably be a part in providing technical assistance to Capitol Hill. So these are the major options for Medicaid reconciliation that we're going to talk about today: per capita caps, limits on provider taxes, work requirements, eliminating the enhanced match for the expansion population, and then lowering the FMAP percentage overall. So first, per capita caps. Per capita caps are really an evolution of caps generally. I think the overall idea of caps was to, or block grants, was to provide some certainty for the federal government on what the federal spending would be on Medicaid. Per capita caps is an evolution of block grants in that we have recognized that when the economy of the state is down, Medicaid rolls go up. So people lose their jobs and fall onto Medicaid. And so a block grant doesn't account for the cyclical nature or the counter-cyclical nature, as the case may be in Medicaid. So per capita caps actually puts a cap per individual spending rather than an entire block grant. So today, Medicaid share of costs is split between the state and the federal government. There is a federal assistance payment, matching payment that is called the FMAP, that is that sort of determines what the federal and state shares are. They vary across states, and the variation is based on the basically the income of the states overall. So 50% is the minimum. There are 14 states right now receiving the minimum 50% FMAP, and the highest is 83%. That's the highest that you can go statutorily. The highest right now is Mississippi, and they receive 77.5% of their Medicaid expenditures are paid for by the federal government. The CHIP program, which is the Children's Health Insurance Program, does receive an enhanced match, and they are paid in general about 15% more than Medicaid. The key thing here is that today states draw down federal match based on their actual expenses. So instead of this open-ended actual expenses sort of matching system, per capita caps would shift Medicaid financing to a system of caps based on per enrollee spending. So it's pretty, I mean, the name pretty much explains it. You will get money by per enrollee. So again, if the economy takes a downturn and you have an increase in rolls, your Medicaid payments will go up from the federal government to account for those increases in rolls. But there is a lot of complexity around how to make this work. The base year calculation is the base year, and the growth rates are the two most important pieces of this, because you need to decide on a base year that works for your state. The last reconciliation package, called the Better Care Reconciliation Act in 2017, set the base year based on 8 consecutive quarters of state expenditures, and those quarters would be chosen by the state. There is also a formula that is applied to that to establish what then the base rate becomes per capita for your state. The growth rate is a big discussion of a big part of the discussion because you want to make sure that it grows over time to match the expenditures in your state. The consumer price index rate is one option, the medical consumer price index or the Medicare economic index. Those are three sort of options. You may have noted yesterday, MedPAC voted on physician payment and came up with the medical economic index as the best way to increase physician payment in Medicare. There are, again, some complexities related to what to do with high spending state versus low spending state or fluctuations in state spending, but this is a flash webinar, so we won't get into all of that. This generally is where the savings come from over time, which is that the growth factor doesn't generally keep up with actual spending. And this is the nature of switching an open-ended program to a capped program, that over time, the expenses generally outpace what the payments are. So when CBO says that this program is going to save money, it's generally because there will be reductions in federal spending going to the state. Okay, next, limits on provider taxes. So today, as of 2024, states reported that 68% of their share, so that's their part of the FMAP, either 50% all the way down to 30% of their share of the spending is raised by general funds. So they paid for out of the general fund, and that's generally your personal income taxes or your sales taxes. So that's 68%, but 32% of state spending comes from other sources of revenue. So there's even some tobacco settlement funds still left, but provider taxes is a big part of that other revenue. These provider taxes are essentially a tax levied on healthcare providers. So there's 19 classes of providers that states can levy taxes on, but most frequently these taxes fall on hospitals and nursing homes. And then the state then captures those taxes and uses that money to draw down the federal match. There are some rules associated with these taxes. You can only tax the healthcare providers up to 6% of the revenue that they would otherwise earn from patient services. So right now, obviously, you're taxing them, collecting the money, drawing down the federal match, and the money goes straight back to the providers that you just taxed. So there's like what they call a safe harbor of 6%. So really, it's not an open-ended way of just taxing providers and collecting money based on those taxes. You really can only do it up to the 6% of the revenue that those providers would otherwise have gotten. There are some other rules associated. It has to be broad-based. So you can't just tax nursing homes that are high Medicaid spenders. You have to tax all the nursing homes, which means there are some nursing homes that don't take a lot of Medicaid patients, but still will have to pay the tax. So they might not get money back in the form of paid rates. They also, state can't guarantee that a provider is going to be repaid. So just like I mentioned, there are some Medicaid sort of nursing homes that don't take Medicaid, and those nursing homes wouldn't necessarily see any money coming towards them. So it would be a net loss to them. CMS does approve provider taxes through state plan amendments, and that process is sort of involved. You have to have a public comment period, et cetera, but this is not something that states can do without CMS's approval. If we limit provider taxes or eliminate provider taxes, CBO estimates that we will save $48 billion all the way up to $612 billion. So $612 billion is the elimination of the provider tax, and all the numbers in between are some form of limiting provider taxes. There has been a long, long history of being skeptical of provider taxes. They've been called schemes, opaque, not transparent. They've been called, states gaming the Medicaid system, because essentially you're taxing providers that then get the money back through Medicaid payments. So this I would be surprised if this didn't show up somewhere in a proposal, either through reconciliation or eventually through a rule at CMS. There was a rule that before President Trump left office previously called the Medicaid Fiscal Accountability Rule that did implement limitations on provider taxes. So I expect to see this somewhere. And again, these at the bottom are the options that the Congressional Budget Office has considered. So lowering the safe harbor, lowering it even more, or eliminating outright. So again, provider taxes are very complex, but every single state except Alaska has at least one provider taxes, and most states have 3 or more types of provider taxes. And actually, before I leave this slide, I wanted to mention one more thing. We call these provider taxes, but of late, there have also been MCO taxes. So states taxing Medicaid organizations, Medicaid health insurers to also collect taxes and feed them back into rate increases for MCOs. So even though these are potentially opaque, they really they are a major pillar of financing the state Medicaid programs. Oh, this is what I just mentioned. This is sort of the Kaiser Family Foundation, or KFF, has some good charts on states that have provider taxes. But as you can see here, 3 or more is the dark blue. So lots and lots of states very dependent on provider taxes for their Medicaid funding. Moving on to work requirements. I'm sure you have heard a lot about work requirements. This would save about 109 billion. I'm assuming that number is a mandatory work requirement across states, not just an option. The Better Care Reconciliation Package of 2017 offered the option for states to implement work requirements. We could potentially also see that this year. Interestingly, work requirements have evolved a lot. It's not just work. It could be an apprentice program, or going to school, or volunteering. There's a long list of qualifying activities, and if you want to see those, they are in the Better Care Reconciliation Package from 2017. They were written in the bill, but there are quite a few options available to people, and generally, the work requirements that we did see during the last Trump administration, the applications, it was about 80 hours a month that people had to engage in these qualifying activities. During the first Trump administration, because the reconciliation bill did not pass, states were basically relied on the 1115 waiver program in Medicaid to apply for work requirements. There were 13 states that were approved to start requiring work in their Medicaid programs, and 9 that were pending when President Biden took office. Of those 13, only Arkansas actually was able to move forward. I think part of the reason why some of these states were not able to move forward was there were a lot of lawsuits, really a lot of lawsuits. And so I'm expecting that if we do see work requirements in 2025, they will most likely be part of the reconciliation package, not only because they save money, but also because we do need a statutory change to, to actually, if Republicans really want to see this happen, because of the significant number of lawsuits. President Biden's administration did release an advisory through the HHS Office of General Counsel about a month ago, saying that work requirements were not permitted in the Medicaid program. So that would trigger a potential Administrative Procedures Act if the Trump administration came in and started approving them. So there's a lot of complexity doing this administratively. And of course, if they did it administratively, there would not be savings in the reconciliation package. So last thing I'll say is the Biden administration did roll back the work requirements that were approved in the last Trump administration. Okay, so here is the information about the advisory opinion. I should have said up at the top that we will provide the slides and also the recording. So if you want to go back and look at some of this, and I also forgot to mention that please put your questions in the Q&A and we'll try to get to them if we have time. We have 9 more minutes in this flash webinar, so I'm guessing we probably won't have time, but you can always reach out to us at Serona Strategies. Um, so I think I've already actually gone through most of this. One thing I didn't mention is that in BICRA, the last reconciliation package in 2017, they did enhance Medicaid match to encourage states to take the state option for work requirements. So they gave states an additional 5% enhanced match to implement them. And then they also exempted certain categories of Medicaid beneficiaries: pregnant women, people under 19, sole caretakers of relatives, and kids who are in school who are under the age of 20. So those details can be found in the BICRA legislation from 2017. The next option is eliminating the enhanced match for Medicaid expansion. For those of you who were around during the Affordable Care Act, the federal government required states to expand Medicaid under the bill. There was a Supreme Court case where Supreme Court said that the federal government had overstepped its bounds, and states had the choice to expand Medicaid or not. One of the sweeteners to incentivize states to expand Medicaid was to provide a 90% federal match on the expansion population. So that means that states only had to pay 10% of the claims for the newly eligible Medicaid beneficiaries. And that has continued to today. The expansion population constitutes 23% of all Medicaid enrollees. These are otherwise generally called childless adults. It's about 21 million people. And there is some churn between this population and the marketplaces. So there is churn, again, among this population. High need mental health population. Anyway, so they weren't previously covered by Medicaid. Right now, 40 states have expanded Medicaid. That includes South Dakota and North Carolina, which are both implementing the expansion currently. Under the Better Care Reconciliation Act, the federal match was phased out over 4 years. We might see something like that come again, or we might just see it eliminated outright. So this can save up to $561 billion over 10 years, according to the CBO. That's quite a chunk of money that could be used for other priorities to, extend the Trump tax cuts, or climate or energy, or whatever the other priorities are. So I would expect that we would probably see an elimination of this enhanced match. There are trigger laws in at least 9 states. So those states passed Medicaid expansion, but they put into their rules, into their laws, that as soon as the federal match was not enhanced, that the Medicaid expansion would fall. So there are states in Arizona, Arkansas, Illinois, Indiana, Montana, New Hampshire, North Carolina, Utah, and Virginia, where essentially that expansion population would no longer be covered by Medicaid if the enhanced match was eliminated. And then there are 3 additional states that would take action, that are sort of required to take action to look at the expansion population. So I think we would see some loss in coverage because of the elimination of this. And also, it's a lot for states to suddenly have to come up with 40% more money for 21 million people. So it is, this will sort of have a domino effect. And as I mentioned, there are 3 additional states that have to take action, and those are Iowa, Idaho, and New Mexico. I think this is the final option that we're going to discuss today, and that is lowering the FMAP, the minimum FMAP. So, as I mentioned, there are 14 states today that receive 50% of their FMAP from the federal government, and again, that is the statutory minimum. That is California, Colorado, Connecticut, Maryland, Massachusetts, New Hampshire, New Jersey, New York, Washington, and Wyoming. They there would be a reduction in the statutory minimum, or it's possible that they do some sort of a blended rate. So, instead of having an enhanced rate for CHIP or an enhanced rate for the Medicaid expansion population, they would blend those rates to reduce to a standard rate, which would likely mean fewer federal dollars going to the state. CBO estimates that they would save about $387 billion. But again, we don't know exactly what this exact policy will look like. This, as far as I could see, was not in BICRA, the 2017 package. So we're not exactly sure what the details would be on this. So we have 3 minutes left, and wanted to see, maybe Kristen, are there any questions that we should address in the last couple minutes that we have here?
Yes, let's see what we can get through. So a couple specific questions. Impact on SNFs and long-term care services of a per capita cap for Medicaid.
I think that the long-term care services might be a little bit more worried about the provider taxes, because the nursing home taxes that are prevalent throughout the country are funding nursing home rates. So if we eliminate provider taxes, the rates for nursing homes would potentially be in jeopardy.
Okay,
But per
related
capita
question.
caps, I will say per capita caps really impact the program overall. And one thing that would have to be decided by policymakers is, can you cross subsidize between groups? So you either set a per capita cap across the group, or you set by categories. And in BICRA, they had 5 categories, recognizing that kids on average are about, $3,000 a year, whereas complex adults, dual eligibles, can be, $18,000 to $19,000 per year. So if you put one cap in there, it's probably not as appropriate. And so we expect to see that they will divide among categories, divide people into categories. But then the question becomes, if you have fewer kid expenses, could you then spend that on complex, elderly adults or disabled population? That is a policy question that would need to be answered.
Okay, several other more specific questions around provider taxes. So are ASCs, urgent care centers considered providers, and would they be taxed at the same rate? And then also, do per capita determinations consider partial benefit enrollees?
Yes, there is, under per capita caps, the 5th category was partial enrollees. I think it was children, pregnant mothers, expansion population, um, um, long-term care, and then partial and benefit enrollees.
Okay, we have
And
13 questions and no more time. So maybe one last question, which is going to be a work requirement question. What do we know about what work requirements would look like, and would work requirements extend to other programs like SNAP?
If you're interested in work requirements, I would look at the Better Care Reconciliation Act. There were a lot of very detailed aspects of that bill, and could give you some answers on where we might be going in 2025. Obviously, they did a lot of thinking about this in 2017. Since 2017, we have had many applications for work requirements, which means states have had time to think about it too. So there could have been evolution, but I think you could look there. You could also, you know, there's lots of information. Kaiser Family Foundation, for example, has a lot of information on this. So
Okay, lots of
thank
questions.
you.
Well, we will take note of these questions and please follow up with us if you would like to talk further about this.
Next webinar is cybersecurity, so you'll be receiving an invitation. Thank you.